Hello, hello.
Hello, everyone.
So we already got people telling us where they're from. Good evening from Maryland. Hi, Janet. Hi, Carolyn. Omaha. Michael from Omaha.
I don't think we've had an Omaha before.
Nebraska.
No, it's Racine.
And
Omaha, Nebraska.
Yep. And another Janet from Boston, and Terry from Texas, Kathleen from Washington State, Michaela from Louisiana, Sieta Maria from Spring Valley, New York, Sandra Bowers.
I see some names that I recognize and
Yeah,
some new
regulars.
names. Fantastic.
Several from Texas tonight.
Yeah.
Maybe Sylvia's been drumming up business in Texas.
Probably so.
So we have a good session for you tonight. This was one that Alicia handpicked because she noticed that we have some new changes coming out in April. So this is our community Q&A, and the topic that she's going to be doing is the April 2026 ICD-10 CM updates. So that they are going into effect April 1st, no joke. And she'll go over all of the updates for that. Because you know Alicia, she loves her ICD.
And there's some significant changes we need to be aware of. Yeah.
And then we want to give a shout out, of course. This time, William, who is on our help desk, has become extremely proficient at making beautiful infographic slides and a whole bunch of other stuff behind the scenes that make me and Alicia look really good. So thank you, William. And he says hello to everyone. So if you've interacted with the user help desk on the Academy, that is William. So, and William is a teacher. And so he's using his teaching skills as he's also learning coding with the rest of our students.
Yeah.
So I'm going to turn it over to Alicia, and then at the end, we'll go over maybe some other slides regarding some happenings at CCO. So I'm just going to be Vanna White. I might put up some of your questions as she's going along. So feel free to post them in the chat, and I will pull them in as appropriate. Otherwise, we'll have a little bit of Q&A at the end.
Yeah, I'm looking at multiple screens tonight, guys. So if you see me shifting back and forth, I'll try to pay attention so I don't miss any of your questions. All right.
So Sharon, yeah.
I'm not sharing.
There you go.
Am I sharing now? Okay, perfect. Well, welcome everyone. Now, of course, you know, like Laureen said, I love ICD-10. So I'm really glad you're here today, because if you have been coding for any length of time, you know exactly how this goes. You finally feel settled with the code set, your workflow feels smooth, and then the calendar turns and it's time to do the update. But honestly, it feels like these changes came faster and more often than they did 10 years ago, because they now happen twice a year. So today we're going to unlock the April 2026 ICD-10 CM, and we're going to go through PCS updates as well. Some of you might be thinking, okay, I'm still digesting through October, and that's completely understandable. But this is something you better keep in mind. Mid-year now, the updates are going to be different. In the past, I don't know if you guys have noticed, we might drop 1 or 2 new codes. We didn't get any new codes this time. So you don't have to memorize any new diagnoses codes or start worrying about how to apply new codes, because the real theme for today is going to be a shift from those rigid rules following towards using more clinical judgment instead of just asking, what does the book say? We're going to ask now, what's actually going on with this patient, and how do I translate that into the most appropriate codes? Now, my goal is that when April 1st rolls around, you're not scrambling at the last minute. You walk in with confidence, maybe even leading your team through the changes. That would be ideal, and we can help you with that. So over the next hour, we're going to look at what actually changes. We're going to walk through some examples, and you'll see the real chart, some real chart example type things that we can look at and again explore together. So let's go ahead and dive in. Hold on just a second. Let me hit it over here. There we go. All right. Let's start with the big picture. Normally, again, October is when we see the heavy lifting. October 2025, we had 487 new diagnoses, codes, 28 deletions, and I think 38 revisions, which was a lot to absorb, but we're used to it. So at the start of the fiscal year, we pay very close attention to the changes. But in contrast, for April 2026, it's going to look really different. So this April update, there are no new codes, like I said, and there's not going to be any deletions, and there's no revisions to the diagnosis codes at all. Instead, the changes focus on refining how we use the existing set. This is going to be a little mind-bending. That might sound easy at first, again, but this is really about tightening up the infrastructure and behind the codes, what we do to get to the highest specificity, what we already know, and which can also be as impactful as a new code. If you guys are in leadership roles, it's really important that you pay attention and bring that back to your team. We're also going to look at grouper version 43.1 for any of you guys that do inpatient, and the updates are concentrated in the tabular list, the alpha index, and instructional notes, while the official guidelines themselves are not going to change. Think of it this way. The words of the language or the codes are stable, but the grammar and punctuation, the notes in the index guidance, they're getting all cleaned up, and it's a long time in coming. So that means you absolutely cannot treat this as a light update. If you're used to certain excludes notes behaving one way and they now behave differently, that affects every chart, every claim, and potentially every denial. By the time we're done tonight, you'll know exactly which areas to watch so you're not caught off guard. Let's talk about what's happening with the alpha index, because that's where many of us start our code search. We always look at the alpha index first, then go to the tabular. Now, for April, we have one main term deleted and two main terms added, plus some targeted changes to how certain conditions are indexed. There's also an ICD code swap where J10.1, which is is a code for the flu. It's replaced by J10.2 in the index structure, right? So two of the most important highlights involve Parkinson's disease and neuroendocrine tumors. So idiopathic Parkinson's is now clearly directed to G20.A1 instead of the old G20.C area, which pushes us toward a more precise idiopathic classification instead of just a vague default. Excuse me. So for neuroendocrine tumors, the index now defaults to malignant behavior under C7A, unless the documentation clearly supports something different. So the malignant default is a major change because it immediately increases the implied severity, unless you confirm otherwise from the documentation, which can have a direct impact both on HCC and RAF scores and risk adjustment. But if you're coding for an MA or Medicare Advantage or any risk-based program, a default to malignant versus benign or uncertain behavior changes the risk profile and the budget associated with that patient completely. So the takeaway that you need to think about here is that you cannot rely on how you used to find these codes in the index or having them memorized because they cross your desk often. After April 1st, verifying your lookups, especially for conditions that drive risk adjustment, such as Parkinson's, leukemia types, and neuroendocrine tumors. If you're training new coders, make sure they understand that the index is not just a shortcut. It's actively shaping defaults that affect RAF scores and the overall clinical story. It is a huge change. Shifting over to the tabular list now, the April update comes with a 14-page addendum. Now, remember that it's 14 pages of refinements rather than new codes. So you'll see one chapter title revision and some adjustments to inclusion terms with 2 terms added and 2 deleted, all aimed at tightening up and aligning between the narrative and description and the actual code usage. The most significant action in the tabular list involves the excludes notes, which have 16 exclude 1 notes being revised to excludes 2, and 4 situations where notes shift from excludes 1 to excludes 2 to allow for like a dual coding when conditions truly coexist, because an excludes 1, as you know, is a hard stop, not coded here. That's the instructions you're giving. Now, moving selected relationships into excludes 2 opens up room to report both conditions when the clinical documentation supports that. A little shout out for our CDI course. This is something that we talk about in, I think, module 6 or 7. It's going to come up. So this shift is about matching the coding rules to clinical reality, where patients often have multiple concurrent conditions rather than a clean, mutually exclusive diagnoses. So when a condition moves from an excludes 1 to an excludes 2, it means you can now code both when appropriate instead of being forced to choose one, which directly affects accuracy and reimbursement. Now, as you get ready for April, you're going to need to carve out some time to review these specific excludes changes so you can guide your team. You don't want coders following the old hard stop logic when the updated tabular list is explicitly granting more flexibility, because that can either suppress valid codes or trigger preventable denials if your software hasn't caught up. We've been through that before, haven't we? All right, so let's now get into the instructional note changes. Because these drive sequencing and how we tell the patient's story with multiple codes, overall, we're seeing a consolidation of notes and an emphasis on encounter circumstances rather than, say, a rigid one-size-fits-all order. The old model of primary code, then secondary 1, and then secondary 2, it's going to be replaced with a more flexible, clinically driven sequencing approach, which just makes sense. A big part of the shift is the addition of new code also notes and a code also instruction, which, don't forget, means that 2 codes should be reported together to capture the full clinical picture, not that one is optional or nice to have. Okay, I got an example here for you. So H40.84, neurovascular glaucoma, you're now instructed to also code the underlying conditions such as diabetes or vascular occlusion. So you're not reporting the glaucoma in an isolated situation. Excuse me. Similarly, we can look at F07.81, which is post-concussional syndrome. Y'all see a code also note for the original injury or underlying cause, nudging you kind of to look at the manifestations back to the traumatic event or the condition that triggered it. Now, this is going to reinforce that we're no longer just listing diagnoses, we're actually showing relationships between them, which is critical for both risk adjustment and quality reporting. What do I say all the time? We code for statistical purposes. It happens to be a convenient way to get paid. Now, in terms of sequencing, you're now prioritizing the reason for the encounter, the clinical focus, and the severity of coexisting conditions. Okay, so let's look at scenario A. Let's see, focus on the chief complaint as the first listed code, and scenario B sequences the etiology and the manifestation based on the clinical focus of the visit. And when you look at scenario C, it's going to encourage you to look at severity and resource use when multiple conditions are active. So this framework demands more from your judgment, but also gives you the flexibility to accurately mirror what the provider actually did. And this also means that you have to understand the disease process. Now, if we walk through specific examples that are called out, let's see, because these are likely to show up in real charts. For I-5 1.5, which is myocardial degeneration, and I-5 1.7, cardiomegaly, there is a new excludes one note that applies when these conditions are due to hypertension, which would be an I-11 code, or due to hypertension with chronic kidney disease, which is going to be an I-13 code. In those cases, you don't code I-5 1.5 or I-5 1.7 separately. You move to the appropriate hypertensive heart disease code instead. Now, that means if documentation says cardiomegaly due to hypertension, you now go straight to I-11 and you code that, and it captures the hypertensive heart disease rather than pairing cardiomegaly with a separate hypertension code. Now, missing this change is going to lead to an incorrect combination that are now explicitly forbidden by the excludes one instructions. So you can see how this is transformative. For R10.1, upper abdominal pain, a new excludes two note specifically references flank pain, R10.A, and pelvic pain, R10.2. So clarifying that these are different anatomical regions and can be coded together than when clinically present. So if the provider documents both upper abdominal pain and then the flank pain on the side, you're allowed to report both rather than feeling constrained by the previous overlap. And remember that flank pain is a new code that recently had dropped. R40.2A, that's a coma, now has an excludes one note that points you to the coma scale codes, R40.21 through R40.24, which indicates that when a specific Glasgow coma scale is documented, you should use those more detailed codes instead of the general coma scale. So for G00.1, pneumococcal meningitis, the update is kind of a refinement of the instructional notes to clarify when you code also or use an additional code to reflect the underlying infection or related complications. So taken together, these examples kind of reinforce that the goal is better precision with clear linkage between conditions and their causes. Now, I wanted to give you just a brief look. It's not pretty, but these are a list of the 16 changes that came up with the excludes. However, best practice is for you to go out to CMS and pull the list. This make sure that you're on top of that. And then we're working on a free white paper so that you can download that and take that back to work. You can get this at the CCO Academy. And then we'll tell you how to do that later. We've got it in the works, and we know that it'll be really helpful to you. If we translate all of these rule changes into what they mean when you sit down to code on April 1st, the biggest philosophical shift is that we're moving from this rigid, exclusion heavy rules to a model that expects you to exercise clinical judgment while still honoring the instructions in the tabular list and index. The excludes 1 to excludes 2 transition in 16 cases is central because it opens up dual coding where conditions genuinely coexist. And to be honestly, our hands have been tied in this for quite some time. And in addition, this also means you need to improve your understanding of the disease process. If this is a problem or you think that you have a little bit of a handicap there, I would encourage you to look at one of our ancillary courses on pathophysiology. Now, what this is going to mean is if you have a patient that has 2 distinct conditions that used to be blacked from being coded together because it had an excludes 1, you may now be able to put those both on the claim, provided the documentation supports the concurrent clinical active condition. Now, in risk adjustment and value-based care, this better captures the patient's true complexity, which directly affects both the RAF score and resource planning, the RVUs, and it can also affect the DRGs. So sequencing is also more flexible, especially in scenarios like the I-16.1 hypertensive emergency. So if the patient presents with hypertensive emergency, which is the I-16.1, and remains your primary code as the reason for the visit, then any associated organ damage is sequenced as secondary instead of a fixed order that might not match the actual encounter. You focus on the primary clinical concern and then layer in the manifestation and comorbidities based on severity and resource use. It's quite brilliant, right? So from an operation standpoint, you want an audit action plan for early April. Focus on claims where excludes notes changed and confirm that your software and edits aren't still enforcing the old rules. Test those cases. You can use the grouper V43.1, monitor denials, make sure your team is, consciously applying the new flexibility rather than coding just on autopilot from what we're used to. From an operations standpoint, you'll also want to look at outpatient as well. Now, in parallel, build an outpatient tracking stream that evaluates how the same diagnosis and procedure changes behave under OPPS, which is your outpatient code editor, your OCE, and claim edit tools. I would pull a small sample of high volume APCs and newer revised, say CPT or HCPCS codes, scrub them through your updated edits, track any shift in APC assignments, status indicators, and packaging or pass-through logic. Now, for the first 1 or 2 cycles after the April update, trend outpatient denials and rejections separately, maybe by payer or department, so you can quickly spot any new edit conflicts. There's always several of them. You can do a side of service issue or medical necessity denials driven look by the code changes and kind of close the loop with targeted education or fixes because you don't want to be scrambling at the last minute. For those working on inpatient setting, there's an additional layer of the PCS side. Now, while ICD-10 CM is focusing on refinements and instructional notes, PCS is gaining 80 new procedure codes and 2 deletions that apply to discharges from April through September of 2026. These changes are especially relevant for hospitals where missing a new qualifier can affect the DRG assignment and reimbursement. It can be very weighty too. One highlighted area is going to be 5AO, which adds new ways to capture cardiac output monitoring and a key element for high acuity and ICU patients. Another set of changes involves the FO7 and the FO8 for electrotherapy and wound management. What they're doing is they're expanding how we can document advanced wound care and related therapies often tied into complex chronic conditions like diabetic ulcers or pressure injuries. Now, because of these conditions, it's critical that your encoders, your EHRs, and your billing systems are updated so that when these providers document the procedures, your coders can immediately select the correct and specific PCS codes. Work with IT is a good idea, and the CDI now ahead of time to see how, say, the 5AO or the F07 and F08 codes like flow from documentation through the claim system, so you're not troubleshooting on live discharges in April. That'll be a real pain. You can and should download, of course, the full ICD-10 PCS files. You can do that directly from CMS and see exactly how these new qualifiers fit into your facility and code sets and their DRG logic. But the sooner you integrate and test, the smoother April through September for discharges are going to be for you, for PCS. Now, implementation, so that this doesn't just say theoretical, first you need to update your systems. Make sure your EHRs and encoders and billing platforms with the official CMS and CDC fiscal year 2026 files are ready to go. Verify that your grouper, the V43.1, is ready and in place for inpatient. Now, if your software is still treating a revised excludes one note like a hard stop when it should now be an excludes two, your team is going to end up fixing preventable errors manually, which is a headache. I know the ones of you that do that know exactly how hard that is to do or frustrating. So I would work with IT now, run some test scenarios, especially those involving those 16 revised exclude cases, and confirm the RAF calculations, the sequencing, and the edit logic that they reflect the new rules. That's why I wanted to make sure that 16 was listed on the slide deck. Don't assume that your update from the vendor just works. You need to push examples through so you can see how the system behaves. If it flags valid dual coding as an error, you know you've got some configuration work to get done before April 1st. You don't be scrambling at the last minute. Second, plan targeted training instead of one big data dump. Focus sessions on the excludes 1 and 2 shifts, and then maybe the code also notes. And use those specific examples like the I-16.1, the hypertensive emergency with organ damage, so coders can practice real scenarios. Reinforce that golden thread concept that we talk about all the time. If the provider is monitoring, evaluating, assessing, or treating, which we call MEET, then again, excuse me, the documentation supports it, and you have more flexibility to code both that complexity accurately. Now, third, you should really build in and practice an audit readiness. So what I suggest is you run a mock audit using April criteria on, say, recent charts and ask, are coders faulting to unspecified codes when the updated index would lead them to a specific code, like, say, the G20.A1. Review how your team is handling the revised excludes note and use resources like Coding Clinic, the high acuity summaries, and official CDC and CMS guidance to resolve questions consistently. Now, before we close, let's make sure you know where to find the official materials you need. So again, the CDC, the NCHS site provides both the alphabetic and index addenda and the tabular list addendum. And you're looking at fiscal year 2026 for the ICD-10 CM files, and then along with the grouper version 43.1 resources for inpatient. And you'll want to download those directly from the site rather than just relying on secondary summaries. So you have the primary source at your fingertips when you have questions that come up. Because again, what we're presenting to you today is showing you the impact and what we have available to us, but the actual list comes from, the CDC. So go to cms.gov. It's always your go-to for additional Medicare and Medicaid billing guidance related to any of the updates, including any nuances in how they expect claims to be submitted. Now, for a deeper explanation and tricky scenarios, of course, we have Coding Clinic and high acuity summaries. They're excellent references, especially if you're working with risk adjustment or HCC coding and need to understand a RAF impact. But don't overlook both coming to CCO and other professional communities and blogs, because actually your peers often end up being real world issue experts, and they have workarounds and faster than formal publications. Honestly, they're in the trenches. So the more you stay plugged into those conversations, the easier it is to get the benchmarks and fine tune your approach and catch any potential pitfalls. Now, I would say we can go to our Q&A, but there's another idea I want to leave you with, and it's starting April 1st, refine your workflow for flexibility while sharpening your precision. Now, this update isn't about, again, cramming new codes. It's about thinking differently, using clinical judgment, and making sure your sequencing and dual coding reflects what actually happened during the encounter. The rules are absolutely more flexible, which means your analysis of the documentation needs to be more precise, your clinical understanding a bit deeper, as I said before, and your auditing more intentional. Now, if you update your system and you train your team with real scenarios and test your processes ahead of time, April 1st can feel like just business as usual instead of being chaotic. Now, from here, this is a great point to open things up for questions, but what I want to do is go back to that one page where I listed the 16, because I want you to see a couple specifically that were going to affect me in my daily use, and I want you to have a heads up about those. So let me get back real quick. Let me stop sharing for just a second. So it'll only take me a second to move back through my multiple slides.
You got through that pretty quick.
Well, yes, but now I want to really, look at this page right here. And is that too small? I hope it's not. Oh, let me share again. One moment.
Everyone's quiet tonight, listening with rapt attention.
All right. So the ones that are, well, they're all really important, guys, but anything that has to do with liquid, so this lymphangioma, now they changed. So they went from excludes ones with D35, D22, and Q82, which again, Q82, all your Q codes are genetic codes. Now they're excludes too. So all of these have gone to excludes too, meaning that you can code these codes together. Neutropenia, very common. Let me take you down here. Deficiency of other B group vitamins. You see that all the time. Huge, huge one here. Number 7, migraines. How many of you have always known you cannot code a headache and a migraine together because of the excludes one note? We weren't allowed to do that, but we saw it all the time, especially if you work in neurology. But the patient has a headache and they have migraines, but you have to code for migraine. Now you get to code them together. Pop, right? Another one. We talked about the let's see, the I codes, but rheumatic aortic valve disease, you can now code with other valve involvements. We did, there J95 post-procedure respiratory failure. I see this a lot because I work with the ICU patients. The excludes one J96, not elsewhere classified, has been moved to excludes two. Dysphagia, incredibly common, is now had excludes one for heartburn, is changed to an excludes two. Poisoning by psychotropic drugs, I don't know that I necessarily see that one as often. However, let's see the so the neoplasms versus vascular nerve codes. These D codes, that's all blood codes. And long-term current use of opioid analgesics now can be used with F11.9 and F112 methadone use codes. And then this goes back down to heartburn and dysphagia, being able to, if we just look at those really quickly, you can see how common some of these codes are. And we've been doing the migraine and the headache. That is just a huge no-no. So all of us that have been coding for several years, this is a shock to our system, and we're going to have to backtrack and not be old school. And don't think this is the end. This is going to happen next year. I guarantee it. We're going to see a few new codes drop, but the whole thing is a change in the way we capture. We're moving towards AI assisting and making sure we don't miss diagnoses in the disease process, where common codes that are used together or diagnoses that are seen together are not excluded anymore. It's the reality the patient can have both of these at the same time, so therefore it needs to be captured. Again, focus on the disease process. Got to bring your knowledge up. So that's why also CDI is going to be really, really important. So I'll stop sharing this, but this is the beginning of a huge game changer moving forward. It is equivalent, in my opinion, from when we went to 9 to 10. This is the first step in the process of us shifting the way we translate. The rules are changing. The guidelines haven't changed, but the rules for the tabular and the index, they're a changing. So heads up, guys. Okay, I'm going to stop sharing.
Any questions? Put them in the chat. How many knew that the ICD codes, we always do a big update for, 2026, but how many like actually go, oh, I got to be ready for the April changes?
Right. And in fact, they were just talking about this at the university, and I had sent a memo out and said, hey, there's significant changes for April. And one of the coders sent back and said, we already did the code changes. There's no code changes in April. She didn't know what we were talking about. And I said, and actually my boss, I told her, I said, she goes, what's going on? And I said, no, ever since COVID, when they dropped that new COVID code in the middle of the year, that opened it up that now we have changes twice a year. And usually it's little tiny stuff, maybe one code here and a few little tweaks. And this one was the biggest one I saw, and those coding spidey senses jumped up and said, this is going to be a real problem. This is going to be an issue if we're not on top of it.
Yep.
Yeah, Maria says she wasn't aware that this was going to happen. And again, usually it's real subtle. We just get one or two things changes. This is one of the biggest ones I've seen, and it's going to be really impactful if both financially, it's going to delay stuff because the denials are going to happen. And I guarantee you that the new systems are not going to keep up and the payers are not going to keep up. So April 1st drops. So I would say half of this is going to work and the other half isn't. And so that means all of your billing people are going to be scrambling to adjust. That's why, I iterated several times that you need to be practicing this now so that when you have a rebuttal as to, why this claim was thrown out, well, because those codes can't be coded together. As of April 1st, via they can. And so that can be readjusted. So you want to be aware.
So Sarah's asking if this webinar will be public. Yeah, all of our webinars, except for our student calls, we broadcast and anyone can watch them. So the best way to send coworkers to it is to our YouTube channel. So it's youtube.com/@CCO. And then you can just look at the last live event and they'll see this one. I also put the link to the YouTube video in the chat earlier. You can go ahead and just share that. That will be just a recording of this live event that stays up.
I would also suggest we'll have it up in a few days, but we've done kind of a memo format or a white page. I don't know.
White paper,
yeah. White paper on the updates so that you can take that back to work and make sure that you're prepared or your team's prepared and give them a heads up, because who said it? Kathleen nailed it, said, yes, previously April updates were minor. Encoders need to be updated quickly in April. And so for those of you that are working with your books, you don't get new books in April. So your manuals will be outdated for a lot of this major stuff that crosses your desk for the excludes and also the code firsts and stuff. And if you do inpatient, that can be very impactful as well.
And with the ICD-11, Alicia and I were working on an ICD-11 project, and it's going to be impossible for that to be a printed book. It just, it is meant for the digital age. So it's just something to start getting used to the digital. I do agree, learning from paper manuals is so key because you understand the layout and the format. So when you're using an encoder, you understand it in context. But for ICD-11, it's so crazy different in long, hairy codes. And, it's like you kind of build the code every time you go to code. So it's really kind of impossible to just have a book. It would be so thick, like you just couldn't carry it. So,
and we are definitely moving out. This is also an indication of how we're moving away from paper manuals. But yeah, you caught that next comment. The changes are on the CMS website. You can go ahead and pull those, download those, and I encourage you to do that. It's not in a pretty format though, but there are ways to, maybe you can use your AI tool to help you make that pretty or make it relatable to your specialty. Because again, some of these may not necessarily cross your path, but I'm surprised how many of them are. So absolutely do that, or come back for our white paper. We'll spell that all out for you pretty easily. And now, yes, as of April 1st, headache and migraine can be billed together because of the new excludes. They both have to be documented. Of course they are. We see that all the time. You'll see the A&P and they'll say, the patient has hypertension, the patient has, a headache, and migraine, and and you have to drop headache and code for migraine. and it causes a lot of confusion. And that is the first one I saw when I was going through this, and I went, what? Wait a minute. That, because I have a lot of rebuttals on coding audits regarding that.
What do you mean rebuttal?
So a rebuttal is when a person's audited, whether it be the physician or a coder, whether it's an outside or it's say a federal audit. They give you your audit results, and remember, an audit result is an opinion, usually with the idea of education, not necessarily being penalized unless it's a government audit. That's why you want to relish those audits. You're always being educated. And routinely, you'll have 1 to 2. If you work for a large entity, you should be having 1 to 2 audits a year. Then when you receive your audit and you go through and you look at it and they say, you coded it this way, but it should have been coded this way, and why? Then you can come back and say, well, our policy is to code XYZ. So if, for example, I coded a headache and a migraine code on the same encounter, as of today, that would be incorrect, because the guidelines or the excludes tell you that you cannot code migraine and headache together. And so let's say I did that, let's say I audited you. Let's put you in the hot chair. You did, then I would educate you and say, it says here, because of the excludes, that you cannot do that. Now, if you disagreed with me, you'd have a rebuttal. You have the chance to give your side of the story. And sometimes there are policies in place with your organization that direct you to do something a certain way. Sometimes it's a non-billable encounter. It's in the global days, and there's all kinds of reasons that you may not be capturing everything. However, it's your chance to come back and state, this is the reason I did this. My understanding is we do XYZ, and you suggested we do ABC. So I've had some really interesting rebuttals. Sometimes I'm wrong, even as the auditor, and will argue on some fine points, and it's not really arguing. They'll put forth what their thought process is and mine, and then we'll come to an agreement. A lot of times, if we can't agree, it goes up to higher power. So maybe the directors come in and say, we present our information, and they say, okay, we have to make a decision, and they'll go one way or the other, and then you turn them into policies. But a rebuttal is just a way for you to have your voice heard and give kind of your side of the story. And you do that both with government audits too. When we were doing home health, they would come in and really scrutinize you. And I remember there was one where there was like 20 deans that they came in, and we all sat around this table and we explained every single one of them, and we had information to back it up and so on and so forth. And every single one of those were given back. What those deans, we call them, they were given back because we were able to articulate and put forth why we did what we do, and we validated it. And because they're paid to find mistakes. So any type of a red flag, that then they jump on that. And so it's
so basically
exciting.
A rebuttal is like a you're fighting them
Yeah.
one to, yeah. Okay.
So if you
not so
kind
fast.
Right. It's not a negative thing. I hate to say it's a negative thing, because it's really an educational process, both for all of the parties involved. And sometimes, coding is not black and white. And the more you understand the disease process, some of the rebuttals that I get conversations on would be coders saying, well, how am I supposed to know that? Well, because you have to know that this is a high risk medication, or you have to know because it's your job to translate. And that's where that disease process and pathophysiology, the longer you've been in the system and you read these notes and you know the outcome, then you're
Right.
better. That's how you specialize. And that's why the CDI course is really huge right now, as well as I would say the pathophysiology, the pharmacology, all those ancillary courses are going to build your knowledge base up and make you better at what you do.
Yep.
And so that way you can articulate better when there's a rebuttal. I did this because the clinician stated, ABC. And when I see that, it means, I know it because, anyway,
Right.
it's good stuff.
So we just got the two last questions. One from Carolyn. May we have a copy of the presentation? And me too. Do we have access to the presentation on YouTube? You've got the video. Everything you just saw tonight, you'll see. But if you want the actual like PowerPoint, transcript, all that, that's part of our club membership. That's how we make our living. So we would love it if you became a club member. It's 24. Oh, actually, that's a good segue for me to go into finishing my slides. So
Yeah.
Mary
And
doesn't spank
while
me
you're
later.
doing that, Sarah said it's important to know your organization's coding policies. Absolutely. It is
Yeah.
absolutely correct.
Yep. Good one.
Very
Good one.
important.
So this is just a reminder slide about our club. So if you want to join, if you're not a member already, go to cco.us/club. It gets you CEUs that we do. We normally at least have one CEU a month, sometimes more. It depends on, quite honestly, guys, AAPC raised their prices again.
Oh,
So I think it
yeah.
was $330 for one stinking CEU. Now it's $412. So they're making it harder and harder for all of us, because then we need more members just to get the same number of CEUs. And what we want to do is give you more CEUs. So anyway, complain to the AAPC, will you? So this is where you go, but we have all of the beautiful slides. You can have just the slide deck, or we have the transcript, which is the slide with all of the words that we spoke below it, which is really nice because you can then do Control F and go look for a particular phrase, or, you heard Alicia say something, you wanted to go look it up. We have that. The other good thing, as a club member, you get access to our Cody bot, which is our AI agent that is trained on all of the content in the Academy, every single course, every single ancillary course, all the webinars, every webinar we do. Everything is kind of, I say, slurped up by our AI, and you can ask him any question on anything, and it's very, very helpful. Also, for on-the-job stuff, maybe you got a tough op report or you're struggling coding it, you can ask CodyBot, redact it, and say, I think the code is this. What do you say and why? Give me your rationale. And not that you just trust it out of the box, but it will get you thinking on the right path. And of course, as a club member, you can ask in our club area, and Alicia and I kind of vet, op reports, E&M notes, anything that you might be struggling with coding. If you're not sure about a diagnostic situation, we can help you reason out how to get to the correct answer. We're kind of like tiebreakers a lot of times at work. You might have a colleague that's saying they think it's A, and you think it's B, and it's nice to have a third party weigh in, and a third party who's been doing this for a long time. So the club is worth it. These are the prices: $24.99 if you want to do it monthly, or $249 per year, and you basically, in essence, get 2 months free if you do the annual plan. Then we have the CCO Club Plus. That's for people who are also in the learning stage. They want to take 2 courses at the same time. So maybe that medical terminology course and a coding course, or that pharmacology course with a risk adjustment course, or the pathophysiology with the CDI course. So you get 2 courses plus the club and all the CEUs, and it's $329 to get in, but $99 a month. So if you were doing our subscription model, which is $59 a month per course, you've already gotten ahead of the game. You get 2 courses. You can switch out at any time. Maybe you start with medical terminology, like, you know what, I think I'd rather do pathophysiology instead. You just send us a quick note in your private support room that all of our students get, and we'll make that switch for you normally within hours. It's easy peasy for us now. This is our slide to let you know about our CDI course, which is coming along really nice. We're getting very good feedback. it's our first course we're doing with all the new style of slides with infographics and just really good information, which makes those transcripts so nice to have and download and be able to search. So that it's definitely an all-around pleaser because it complements every credential, whether you're inpatient, outpatient, physician-based. This course, most CDI schools either do inpatient or outpatient. This is everything. It's comprehensive. So even if you're going for inpatient, you will now have the knowledge of how it works for outpatient too. It just makes you a better, well-rounded healthcare professional. And this one just took off. Forensic coding specialists. We did a webinar a couple weeks ago, and I happened to present the topic on the forensic coding that one of our members asked us, to present on. And so I learned a lot just in, the interns pulled the information, but in reviewing it and vetting it and then presenting it, it's like, wow, this is so interesting. So a lot of people are like, is there a credential for that? No, there's no credential for it, but a lot of people want to learn more about it. So we're going to be making a course. When we're done with the CDI, we'll start working on this. So if you want to get on that early interest list, those are the people that will be offered 50% off when we're ready to start taking founding students for that course. So check it out. Let me see if I can grab this link here without. No, I can't. Oh, I'll grab it from here. Here we go. So I'll put that in the chat if you want to sign up for that. This doesn't cost anything. It just puts you on an interest list. All right. And this is our pricing table. We actually started this in the fall of 2025, but we call it our 2026 pricing table. I guess we're like ICD-10. I don't know. But we now have basically two pricing options for all of our courses: rent or own. Rent, $59 per month per course. And own, you pay the full price, which is, normally around $14.47 for our full courses. I think $7.87 for our ancillary courses. And when we do have sales, the most we go down is 25% off. So the lifetime access gets you the course for life, and you get the blitz that goes along with it, practice exams, extra phone calls if you need it. So there's more bonuses with it. But if you're on a budget, or what often happens is you've already signed up for another course and you have regret because the lectures are boring or the support is hardly there, you can come join us for $59 a month, get support from us, and supplement with our lectures, which are like the style you saw tonight. So yeah, rent or own for courses and blitzes. And our YouTube channel, I already mentioned earlier, is just youtube.com/@CCO. If you could subscribe, that helps us a lot. Share it with your friends. That doesn't cost you anything, but it helps support us. And, we get a lot of leads from YouTube, so we really do appreciate that. Oops. And this is our schedule. Pretty much Thursday night is CCO night. So tonight we are doing this second Thursday, we're doing the CCO Community Q&A. So all these questions come from you, although tonight was Alicia as a member submitting the topic, which I'm glad she did. And then the third Thursday is our club. That one normally is the one that gets the CEUs. And then the third Thursday, we have the student call. That one is not broadcast. It's internal to our academy, but club and student members are allowed to attend, and it's a very intimate group. You get face-to-face time with me and Alicia, and we don't have any topics selected, and normally we cover something really significant and profound, and the people that are on it are so glad that they popped in. So come join us if you're one of our premium members. And the only one I missed, I think, the first Thursday we do a podcast, which is on Apple Podcasts, Spotify. Those are more lighter topics. Even though we do use visual aids, you could actually listen to it and still get everything out of it that you need to. Kind of career stuff we talk about. Oh, do you want to pivot into this different area of coding? So that's what that's about. We do have an affiliate program. If you want to apply, schedule a call with me. This isn't just for like anybody to just join. And we are going to have a referral program, which is a little different. Affiliates are people that have a following that, maybe they have a big group on Facebook, a big coding group, and they want to promote CCO and get some, money for it, then become an affiliate. And our new platform, we launched it in July. It's going great. We love it. We told you a little bit about CodyBot. One of the reasons that prompted us to do it is we wanted something more mobile friendly, because we ourselves use our smartphones all the time and our iPads. So now you can listen to a lecture on the go. There's some things that you really want to do on a bigger screen. iPad works fine. Laptop for like taking your test where you want some space. But you could listen to the lecture and still get a lot out of it. Even with the nice infographic slides, you can still see it pretty good and still watch it on your phone. So, and of course, it's easy to communicate with each other in the discussion areas. You can even dictate, what you want to say. You can dictate a question to CodyBot. So you could be at work and you're stuck on something. You could say, hey, Cody, I'm trying to code this situation for diabetes and da-da-da-da-da. Of course, no patient information. And he'll help you by digging into all the lectures we've ever done. And so it's vetted CCO material. It's not going out on the internet to God knows where. Where it's getting its information. If you're just stuck and you're not sure what course to take, what you want to do, maybe you're already taking a course, you can schedule a call with me. I do calls in the evenings and Saturday mornings, evenings like from 4 p.m. on. So just go to cco.us/Lorene-call and you can get on my call schedule and we can do like a Google Meet. And if we need to share desktops, we can do that, or you can not show your face or just dial in by phone using the Google Meet. Very easy. And last but not least, we want more topics. So write in, just go to cco.us/topic-request. And this is the new one from Leanne. So she in March passed her CPB exam. And she said, CCO has taught me so much. I've taken many self-paced courses, but CCO is hands down the best. The course material, quizzes, especially the review blitz, helped me feel confident going into my exam. I passed with an 85% on my first attempt with 1.5 hours left. Well done. The instructors, community, and support made all the difference. They even helped me pass the CPCD on my first try through their helpful webinars, videos, and the BAT technique. Next up for me, she's going to be going for the CPPM. That's the practice manager one, the CPMA, the medical auditing, and RCMS, radiology. So wow, very good. And that's an interesting point, that even though she went for the CPCD, which I believe that was the derm one, the dermatology, the methods, the general methods of how to take a test, of how to attack a multiple choice question, process of elimination, the art of skipping, all of these things we include as a club member in our Bat Cave, bubble, highlight, annotate technique. She applied to the specialty and passed. We didn't have a specialty course. She just applied those general techniques. So congratulations to Leanne Johnson. And this was hers from January for the other one. So yeah, so let us know when you pass. You don't even have to have, taken our course. You might have benefited from one little CCO thing. Just go to cco.us and you'll see in the contact us area, I passed. And you just formally tell us there that you passed. And that kind of kicks off where you give us permission to share your information. And in our academy, we have a wall of love where we share, people that have graduated or have said, nice things about us. So, yeah. So
we like to share that because it's real important. I think it
Oh, yeah.
not only makes you feel good, but it also encourages other people.
Celebrate people's successes. And all of our students get a private support room in the academy, and the coaches are in there, me and Alicia and Sylvia, and the help desk staff are in there. And we just cheer you on, like, oh, you got a 98 on that test. Great, good job. Or, oh, your pace is really good. Or sometimes we get people that are getting low scores and then they retake the test, and then the next low score retake the test. And go, okay, as your coach, I need to tell you, you're rushing. You're rushing the material. Take your time, and then we'll show them, look, with CodyBot, before you take your unit test, have a Q&A session with CodyBot. Say, hey, Cody, I just finished chapter 2 of the PBC course, and can you ask me a multiple choice question, but wait to give me the answer? So that he asks you the question, you choose A, B, C, D, and then he'll tell you if you're right or wrong and why. And you could even ask more clarifying information. If not, I said, thank you. Can I have another, please? And another and another and another until you're satisfied. And then when you really feel like, okay, I got this, then you go take the test and you get a high score the first time. Because retaking a test where you already know the ones you got wrong, the higher score isn't as meaningful as getting that high score the first time. So,
yeah. And I don't know of any other courses that offer that tool.
Not yet, but they will. AI is spreading everywhere, but we were the first.
But that way, if you're up at midnight working on something, I mean, I'm telling you, we're in bed. But if you want answers, you have a resource at your fingertips that's user friendly versus having to wait till we've had our morning coffee and can get back to you.
Yeah, and the AI doesn't get tired. You can have it ask you questions over and over and over and over. If you're preparing for a certification exam and you're just a club member, you didn't pay for the full course, you can ask CodyBot, ask me a multiple choice question, CPC exam style. Can I have another, please? Can I have another, please? Can I have another, please?
I think and we've always been known for our rationales, right? How good they are. But I believe the CodyBot will do that too, where if you got number 3 wrong, it gives you the rationale, but you don't understand why your answer is wrong. I mean, it'll articulate that for you.
Yes. Yep. And we are using AI extensively to flag. We have a database of over 50,000 multiple choice questions in our database. And so every year, it's what our poor interns help us do, is to vet all the questions to see if they're up to date for 2026. So now we're using AI to flag. So like this update, we could say, okay, all the ICD questions that we've tagged ICD, scan them and let us know if any have any codes that have been deleted or changed. And now we'll know what ones to go in and edit. So it's really, AI is very cool. Don't be afraid of it. View it as an assistant, because that's exactly what it is. A very helpful assistant that you always have to vet and verify. Don't just trust.
Marcine says, how do I become a member? You got me sold on CodyBot.
I love it.
Let's see.
CCO.us/club.
Yeah. And then Terry, talk full of information. Greatly. So you guys, we really do advertise by word of mouth more than anything else. So we appreciate you coming to our webinars, letting us educate you, and then you in turn letting us know how we've helped you or what information you need us to unpack for you. And then we like to create those things like white papers and tools that'll help you at work, because somebody's got to teach everybody at work. It might as well be you, right?
Yeah.
Have fun with it.
Be the hero. All right. Well, that's a wrap, everyone. Thank you. And thank you, Alicia. Great topic. And thanks for presenting. I was happy to be Vanna White and take a little rest. We'll see everyone next Thursday is the student call. So in 2 weeks. So be well.
Bye, guys.
Looking for medical coding, medical billing, and risk adjustment education? Learn more at cco.us.